Hello, my name is Zixin Shah, and I'm a second-year medical student at the University of Florida College of Medicine. Pembrolizumab, also known as Keytruda, is an immune checkpoint inhibitor that acts by blocking the programmed cell death protein 1 receptor from binding to its ligands, thereby allowing T lymphocyte to attack tumor cells, as illustrated in Figure 1. Because of its mechanism, it simultaneously reduces self-tolerance and may trigger immune-related adverse events. One rare but potentially fatal example is acute autoimmune damage on the endocrine pancreas, leading to autoimmune type 1 diabetes mellitus. Here, we describe a case of fulminant autoimmune type 1 diabetes induced by pembrolizumab monotherapy, presenting as hyperosmolar hyperglycemic state and diabetic ketoacidosis. The case involves an 80-year-old man with metastatic non-small cell lung adenocarcinoma in remission on pembrolizumab and subclinical hypothyroidism. He presented to the emergency room for 1 month of polydipsia, polyuria, and 10-pound unintentional weight loss. He received his 14th infusion of pembrolizumab 2 months prior to presentation. His initial vitals were notable for hypertension. Initial laboratory evaluation revealed severe hyperglycemia at 737 milligrams per deciliter, elevated diabetic range hemoglobin A1C to 17.4% compared to his baseline of 5.9%. Elevated beta-hydroxybutyrate, ketonuria, and elevated serum osmolality as shown in Table 1. He was diagnosed with hyperosmolar hyperglycemic state and mild diabetic ketoacidosis, and was subsequently admitted to internal medicine with endocrinology consultation. His serum glucose was improved to less than 200 mg per deciliter with fluid resuscitation and intravenous insulin infusion. His sudden onset of symptoms, exposure to pembrolizumab, and new onset diabetes with significant hemoglobin A1C elevation suggested rapid pancreatic failure, concerning for an immune checkpoint inhibitor-induced diabetes. To confirm the diagnosis, autoimmune testing was performed, with results shown in Table 2. The patient demonstrated insulin deficiency with a C-peptide of 0.3 nanograms per milliliter and positive glutamic acid decarboxylase 65 antibodies at 30.8 units per milliliter. Following stabilization on an insulin infusion, his course was complicated by recurrent hypoglycemia, first episode in hospital and again 9 days post-discharge, where he presented with neuroglycopenic tremors and dysarthria. After significant insulin de-escalation by the endocrinology team, his glycemic readings have stabilized between 90 and 150 milligrams per deciliter. In coordination with oncology, he continued receiving pembrolizumab, and he remains insulin dependent. This case demonstrates that immune checkpoint inhibitor-induced autoimmune type 1 diabetes can present with catastrophic and rapid metabolic decompensation, and present with mixed features of both hyperosmolar hyperglycemic state and diabetic ketoacidosis. While current literature recognizes combination immunotherapy and pre-existing type 2 diabetes as major risk factors for checkpoint inhibitor-induced diabetes, this case demonstrates that pembrolizumab therapy alone can precipitate this condition as well. Furthermore, pre-existing endocrinopathies may signal a higher risk for polyautoimmunity. Ultimately, we recommend routine glucose monitoring at every immune checkpoint inhibitor infusion cycle to ensure early detection and safe management of this permanent and life-altering condition.